Judge. So I just put together some things, and we'll give you the microphone. Start. So we have 3 neurosurgical colleagues and 1 orthopedic colleague.
I think I'll be okay.
The judge is totally indifferent to this. Is Dr. McGuire. So this is a great group, and this is again the first part, thoracolumbar spine. And as always, we want to think about the dimensions of patient factors, surgeon experience, resource availability, injury severity, and the various modalities we have at hand. So this is about a problem patient. This is a classic scenario. 2 quick vignettes. 43-year-old female fell 20 feet skiing. Very sophisticated person, had a loss of consciousness, was seen in an outside hospital, then transferred in. Severe thoracic and lumbar pain, mobilizing several days. She was put into a brace. She hurt on both locations. And again, I can't give you an MRI scan. I don't know why, but these are the 3 injury locations, T8, L1, and L3. And just briefly, maybe going from right to left, Dr. Ramey, Houston, Texas. Do we talk AO? Do we still have a 3-column theory that is misapplied? Do we talk telix or whatever? What language do you speak in Texas when you see this? And what do you want your residents to tell you in the middle of the night?
A little bit of a combination for me, but I rely more heavily on telix than I do AO.
Now, why is that? That's not a classification. That's a severity scale.
It's a severity scale. It's a surgical decision-making guide, and I find that the AO is just very cumbersome. And while experts in spine biomechanics and spine surgeons that assess these patients in the trauma setting are pretty good using it, those who aren't as familiar or don't use it often are terrible at it. So for me, I find it just as a bit more universal using telix.
All right. Let's pass the microphone on to Professor Hofstetter. So what language do we speak at Harborview in the middle of the night these days?
It's more AO based. We really discuss, the appearance and the structural sort of components more. I think telix for me is a system that helps us not to forget about, for example, little details like the neurological exam. And so, because an Asia A patient is different than an Asia C patient in the same, with the same pathology. But I think first and foremost, we base it on more structure because as a surgeon, we're more structural. And so it's important how to fix it. But I think both is fine.
Dr. Meziwala, you're a unique surgeon. You're a California private practice surgeon with a very large practice reach, North LA to Orange County, and you're working with a Swiss company. So how do you appreciate this kind of an injury? Is this something that you want to be told about in a certain way? You've heard pro and con arguments. You've heard a Texan go like, I'm doing my own stuff. I'm Wyatt Ramey, and Texas is big. What's your thought?
Yes, I mean, I agree with everyone before me. The problem is that usually when you're called about these things, if you don't have the ability to look at the images online, these are described as compression fractures or burst fractures, and you have no idea what you're dealing with. And so, I agree. I think that in the end, as we look at these things from a structural standpoint, the real question is, are they stable or not? This is a neurologically
intact patient. Motor score 100.
Right. So, for me, if I can't get an MRI, like mentioned before, then getting upright X-ray will be important.
So pass the microphone off to our California colleague to the north of you, the San Francisco, Northern California theme. Which of those 3 fractures bothers you most? Give us a sequence. Is your biggest worry T8, L1, or L3?
So with the T8 fracture, you see a disruption of the pars. So to me, that's the one that's the most unstable. The L1 fracture, there's a compression, there's a wedge, but looking posteriorly, it looks like there may be some interspinous splay, so I'm suspicious of that one being a flexion distraction. And the L3 looks like a compression fracture to me, so that's the one that I have the least suspicion for.
Can you just please, for my sanity's sake, give us the AO classification rundown of what is T8, what is L1, what is L3 in AO lingo?
Yeah, so the T8 You have a disruption through the back, and it's not. It looks like it's going out through the soft tissue, so that would be a B2 fracture. The front, so the B2s we subclassify based on the anterior component. So the front looks wedged, involving probably one end plate, so it would be a B2A1. The L1 fracture is very similar in terms, I'm assuming that the spinous process is gapped posteriorly. Again, it involves some of the soft tissue. So it's a flexion distraction injury that's not monosegmental. So as David sort of pointed out, it's a B2 fracture. This one also involves an end plate, so this would also be a B2A1. And the L3 looks like a compression fracture involving one end plate, so it would be an A1 type fracture.
Judge, what do you think?
I would concur with that assessment as far as and I'm even simpler than that. I mean, I love just the A, the B, the C.
Yeah.
And so, you can get really too cumbersome as you start getting into the modifications of those segments. But I would agree fully with the A, B, and the C on this thing. And I think that, to me, makes it simple. I would be more worried in this situation would be the L1. That would be the one that would bother me.
Dr. Gendelberg, can you take a microphone? Did we miss something? You gave us a very erudite, as nice as I've ever seen, by the way, discussion of the intricacies of posterior element injuries. Did we miss something?
No. Per my usual answer, I agree with Ashraf.
Okay, that's why only one of you sits up front. So going back to our colleague from Texas, Houston, Texas, huge place. You see these injuries probably all the time. What is your biggest worry, and what's your advice as to treatment?
My biggest worry, I think, I'm a little less worried about the T8 fracture than Ashraf. I'm a little bit more worried about the L1 fracture, given that I think there is a little bit of a burst component that's there, not just compression fracture, but in the setting of the interspinous widening, I would definitely want to see an upright X-ray and see if there's any significant angulation change there.
So I don't have an upright X-ray. She's been attempted to be mobilized in a TLSO. Kirk Wood has been here several times at this course, and he's a fantastic colleague. He did the only prospective randomized study on operative versus non-operative fractures of thoracolumbar fractures in intact patients. So he's been here multiple times, and it's always surprised me that he's actually a very aggressive surgeon. So although he stated that non-operative care is fine, but we've gotten her up in a brace several days in a row. And here are two confounding factors I need to have you all know. Chris, you don't have to look at that. There's no curveball coming. You're well familiar with what I'm saying here right now. This patient has the Seattle disease, high anxiety. I swear nobody in Texas or California even has an understanding of what's going on up here. I don't know what it is, but high anxiety. And overnight, she became an expert at thoracolumbar fractures thanks to Google University. She has a GD, a Google doctorate. So, I did this. I gave it away. But so this is where we are now. So actually, I wanted to go back here. So this is where we are. So I have one more case after that. This patient has a high anxiety degree. And she's looked at this, and she hurts, and she hurts, and she hurts. So what's your advice? Should we do one thing selective? Should we treat everything non-operatively? She is not happy with her spine as she's mobilizing around, and she has every single paper that Dr. McGuire wrote with and without Dr. Sasso here to basically look at what the biggest worries are.
Is she hurting mid-thoracic or lumbar?
She hurts in all three locations. We've actually already, we're at our second brace. She's been in the hospital for 5 days. This is a true story.
Yeah.
So she has had an initial off-the-shelf thing, and then that was not good enough. I'm not mentioning the manufacturer. So we actually splurged, and we got her a nice custom-made bivalved polyurethane TLSO.
Mm-hmm. Yeah. Without seeing an upright X-ray or an MRI, I think I would be inclined to treat the L1 fracture first, mobilize her, and see how she does.
Pass the microphone off to Dr. Hofstadter. His facial expression has relaxed. There was a grave concern in your eyes before. And why did you frown so much? What was your worry?
Well, I think one of the issues with this is like, you have like 3 different areas, right? And, I totally concur with the previous talk that I think a standing X-ray here right now is really going to shed light onto this case. So I think it's a little difficult right now to make a decision. I would definitely get a lateral X-ray with her standing in her brace. I think I also would like to know if she's radiculopathy. If she develops an L5, L1 radiculopathy upon standing, then I think the case is clear. The issue here is that, it's difficult to treat L1 without treating L3. I mean, having a small construct that ends at L2 is putting a lot of pressure on L3. So there's not a small solution here right now. And that makes it very complicated. So I think I would wait for the standing X-ray and see what she looks like. You can always refer her down the street.
Ali, you're an MIS maven just like Dr. Hofstetter. Any chance of some, quote, perk screws, my favorite, with some cool new Swiss technology?
Yeah, I mean, again, we're guessing, right, because we don't have an X-ray. Yeah, I mean, she's 49. I mean, if her BMI
43, super active.
43, so yeah.
Totally a goer. 3 cups of Starbucks a day, executive.
If she's willing to have surgery and she's willing to have something that's less invasive, you could just deal with L1 and just, do one above, one below.
Doctor. This is a Seattle patient. You are from here originally. You still have a foothold here.
Sure, I do.
She's the usual patient. She wants no surgery, but she wants the best possible result. Now.
I want world peace.
Yeah, right. I mean, yeah.
You don't have those patients in San Fran, right?
Yeah. I mean, prick screws are nice, and again, I'm guessing. So
your MIS neighbor to the left is kind of making a facial expression again. I'm surprised. Chris, your colleague to the south is humming and hawing.
I think in my practice, I've really gone either it's structural, then you need a structural fix, or it's trim work, and then you can do the endoscope, which you don't believe in. But this is structural. If it's structural, then it needs a structural fix, and that means screws, plus minus fusion. I think I'm all for putting in, like you could internally stabilize it with perk screws, for example, if you want to do that. But I think you really have to think about the mechanics first, and then you can choose your weapon.
Dr. Hofstetter, you witnessed this excellent lecture by Dr. Gendelberg on posterior column injuries. Do posterior column injuries that have a largely bone-in component, and I grant you I don't have an MRI here, have a chance to actually heal well?
So I think at T8, it's at the rib cage, unless she has a sternum fracture, which I think, if she has a sternum fracture, she's a really extreme skier. So if she does not and it's stable, otherwise I think that can be treated with a brace. And L1 really depends on the standing X-ray, and I would also get an MRI and sort of see if there's, a lot of ligamentous injury and what the facet joints look like.
Yeah. Dr. Gendelberg, is that a true assessment? Do they have a chance? Can you get a microphone? Maybe you have to take the judge's seat. You get to be judge, but you can't agree
now I'm concerned.
with your partner.
I mean, in my hands, there's always a chance, but I think it's quite a low chance. It's in a kyphotic segment. It's not fully bony. I would just operate on it and not lose sleep on it.
Yeah. So this is drum roll, so we move on. So this is actually, I got an MRI on her, and these are some of the injuries. Any new insights from these injuries based on the MRI scan? Dr. Gendelberg, David, does that help you? You gave us a lecture on MRI oversensitivity.
Well, I think looking up at the proximal thoracic fracture through the pars, this MRI happens to confirm to me that the posterior ligamentous complex is incompetent. I see some violation over there in the flavum. You could talk about whether it extends posteriorly, but this is kind of the clear as mud type of scenario that I mentioned. But it doesn't change a ton for me.
Ashraf?
Yeah, so I think from the CT, we knew that the T8 was an unstable fracture. There's a disruption through the pars. That's confirmed with the MRI. What the MRI provides is more reassurance regarding L1. I don't see a disruption of the ligamentum flavum posteriorly. And so for L1, ideally, I would want uprights. And so then it's a discussion with the patient, based on sort of whether she would consider operative intervention for the chance variant up top. If we, as David had mentioned, it's a mostly bony injury, so it could be treated with a brace. The brace in her is probably ending at the level of her other injury, which is probably why she's having a fair amount of discomfort. So unless you have a brace that goes down to her thighs, you're not going to immobilize everything, especially if the lumbar pain is a component. So the option would then, I'd recommend surgery for T8 and then get her up and see how L1 behaves. You just need to talk to her that may risk that we come back a second time for a second surgery at a more distal level. But we may, but if it's successful and if it's sort of what I anticipate, we'll preserve all the motion in her lumbar spine.
So, neighbor to your left, the SoCal colleague, does this help you now? And you're kind of humming and hawing before. You're playing the kind of escape game. So, Ali, come on. You were a very decisive guy in your UW days. Does this help you?
That's a different patient.
That's a different patient, I think.
Sorry.
It doesn't help me entirely, but
I give it away, but
yeah, I mean, clearly T8 has a problem. And so, I would agree that based on this, L1 doesn't look as bad. And so my inclination would be just to fuse the T8 segment, right? Deal with the upper part and then see how she felt. And if she was still having issues down below, you could always do perk screws. I mean, she's young and healthy and fit, and so she has a good chance to heal without putting through a long segment fusion.
great. So, Dremel will go to conclusion here. I fixed her only for a thoracic spine, short segment fixation, and we treated her lumbar spine non-surgically with a brace, and she actually had a very nice result. So the MRI in this case actually helped me, reassured me that the lumbar spine was okay. So Bob,
I missed the point.
yes, go for it.
Is that perk? Did you perk those?
Heck no. Hell no.
USS system.
I can give you a whole lectures as to the destruction of muscles. When you're board certified orthopedic surgeon,
Me?
you were a board examiner. Take that microphone. Where do you put your external fixation pins in your quadriceps when you do acute fixation?
It's been kind of funny because we keep going in this same circle, and every generation seems like we have to reinvent the wheel.
Yep.
And so unless you have something that to be able to make bone heal bone, I worry about that.
I mean, that MRI to me did not scream instability. I mean, yes, there was a lot of signal in the posterior elements, and I agree with David, the paper that you brought up with you can't rely solely on MRI because you can't trust it. It's there. The signal is just too messy in the posterior elements. So I don't know if I would look at that and say that's unstable, especially in the mid-thoracic region, which is a very reliably stable region.
I almost imagine it like one of those cartoon ropes where you see like the threads unwinding. And so sometimes you have a partial injury, and whether it'll be competent or not, that's where the uprights come on. Because sometimes it's 50% injured. Is that 50% enough or not? And so just stand them up and see what happens.
I think for me, I probably would have seen this patient back in my clinic in 2 weeks. And even though it's a high anxiety Seattle patient, just kind of
You remember
pulled her
them,
hand
right?
through.
You remember
yeah,
them?
Yeah.
So so my thinking, my justification was I consider this like juggling three things. I'm not a particularly good juggler, but I wanted to take the one that was my biggest worry out of the equation with a relatively low impact surgery and a very low functional long-term implication for the patient. So that I felt very comfortable with. The injury by itself, in an isolated fashion, I would have probably treated non-surgically had this been alone. But for me, this was the approach, and the MRI in this case helped me because, again, the posterior column disruption at L1 was a non-factor. I had the same suspicion that Ashraf had. This is an FDI, a flexion distraction injury. I was never going to treat the lower lumbar or the mid-lumbar fracture surgically. But so this is just, for me, one of those approaches of sequentially kind of getting to a conclusion. But there was a lot of talking involved with this patient.
So Jens, one question I had for you. On the postoperative standing x-ray, it looks like almost she has like 30 degrees of kyphosis down there. What did Dr. Google think about that? Did she bother you about that? Did she ask
No,
you?
this was a bother, but this required. I have longer term follow-up X-rays. I'm sorry, I just in the haste didn't put those in. But she settled at around 20 degrees, 22 degrees. And again, I went through the same kind of evolution as Bob did. When I was a younger surgeon, 20 degrees was our cutoff, and 50% canal compromise was the other instability criterion. Then it went to 30 degrees, and now with AO, there's a knowledge from trauma that's kind of reinventing the wheel and going back towards 20 degrees as a long-term alignment outcomes thing. So we're kind of seeing the seesaw of numbers. Ultimately, the numbers matter less than the patient physiology and expectations.
I think the numbers do matter at thoracolumbar junction. We made a little comment last night. When you have angulation at the TL junction, you start changing the lordotic posture. And so if you have 12 degrees of angulation at the thoracolumbar junction, then all of a sudden you have to correct yourself in the at the the lumbosacral junction. So down the road, I think you wind up and potentially create more issues for the low back when you leave this thing minimally kyphotic, which is, we're thinking 12 degrees. That's not too bad, but that's biomechanically where you start changing the movement at the L5S1 junction. So you start loading those facet joints.
People have to hyperlordose caudally to it and then get foraminal stenosis. Very much like, with flat surgeries, as a flat fusion surgeries.
Yeah.
It's very common.
So final case before we go to our first lab with Dr. McGuire, looking at posterior cervical thoracic junction. 54-year-old male, neurologically intact. He has a 2-level lumbar injury. He's a very large male, as you can see. 10-foot fall. He has a L1 injury and an L3 injury. I've already put some numbers and letters down, but neurologically intact, large, and there's some alcohol involved in his daily life management scheme. So Ashraf, you're laughing. Why are you smiling? Can you give him the microphone?
Yeah, if someone says there's some alcohol, it's a lot of alcohol. Yeah. So again, here you have non-contiguous injuries that are pretty adjacent in your mobile lumbar spine. The L1 fracture extends posteriorly, sort of horizontally through the spinous process, which David told us is unstable. And so that's one that. And then the L3 fracture, it's hard to tell whether it's a compression fracture if there's a posterior component. This would be one I would want to get an MRI for. I probably wouldn't get uprights because you know that he's already going to kyphose over the more proximal L1. And so I would get an MRI just to see what's happening.
No MRI, sorry.
No, okay, that's fine. Then we assume that the PLC is intact at L3, and I would recommend operative intervention.
Do the joints matter? An artifact?
No, I mean, I think that raises the concern, that you have some diastasis in the joints there. It's not, flexed. It's, but I mean, it does, certainly raise a concern. But it's, to be honest, it's hard for me to know what to do with the joints being diastased.
Okay, I'll let you have the chance to change this man's life. You can cure him, or you can give him a mega instrumentation and fuse him from the top to the bottom. And there's not enough alcohol in the world to get him back into his physical labor job, which he is. So what are you going to do? Try him in a brace for a while, see how he does, or just fix him, get one of the variables out. Like I did a partial fix in the previous patient and wanted to see what the other one would do.
Well, the problem is a little alcohol, right? So, how compliant he's going to be, and that's the issue. So, unfortunately, I think that he's going to get more than less. And so, the question about L3 is valid. You're going to fix the upper level anyway. And are you going to stop? And what are you going to do with L3? You're going to go back beyond it. So, I mean, these are real problems. If he's not going to follow up with you, do you just do the entire thing and call it a day? But it's a hard call.
Chris, global fixation, something selective, piecemeal like what I did before?
So I think totally different case, high, velocity impact, 10-foot, big guy, that's at the thoracolumbar junction, 3-column injury. I think that's operative. no questions asked there. Then L3 is, I think you pointed out the L3, L4 facet joint, but I think the real problem is at L2, L3, where the superior end plate seems to be fractured and compressed. So I think, the big question is if you can, for me, the only question in this case is where to stop caudally. Can you risk stopping at L3 if you put really massive pedicle screws in there? Possibly, but probably I would go to L4. I mean, again, otherwise at the thoracolumbar junction, I mean, I think I don't think anybody would treat this conservatively with that sort of, front, B and A fractures there at the junction, big guy, high trauma. Nah.
Wyatt, what happened to rod long, fuse short? There was a famous paper in my generation by a gentleman named Neil Kahanowitz, who basically said just put rods in. It was done open midline, and then take them out when the fractures are healed. What happened to that? Or do a spot fusion? Is that something that you'd still consider? You and then Wyatt.
I think we can still consider the issue that I have up there is, I think you have to have intact, mechanics in the back. So the facet joints cannot be fractured. Often in these cases, if you go to the side, the facet joints are really, the morphology is like totally disturbed. And I think leaving that not unfused is not wise. Also, in him, especially L3, is the anterior column really going to hold him there? Without an interbody there, questionable. Again, like I said before, I think a mechanical foundational surgery for this, where you fix the foundation of this gentleman, I would, decorticate in the back and put a ton of bone down there so that it holds up for the rest of his life.
Wyatt, super competitive environment, Houston, multiple medical schools in one city area, multiple egos, high profile surgeons. What are you going to suggest?
Yeah, for me, this is actually a much more simple case than the last one. For me, the biggest key factor here is the obesity, because you've got a big, huge, heavy lever arm anterior to these fractures that is going to really want to put him in kyphosis, and possibly lead to non-union of these fractures as well. So I would go relatively big on this guy, probably T12 to L4 posterior fusion, and that way it's kind of a belt and suspenders approach. You're not leaving any stones unturned, and hopefully he can get back to his hard labor job.
Judge McGuire, take the microphone, please.
What do pregnant women do with their lumbar spine when they stand up? They've got the big belly out here to maintain their balance over their hips. You hyperextend. So obesity, and I've had a lot of experience in Mississippi with obese people. The biggest problem is trying to brace them. Trying to get enough, sometimes it takes a trailer load of plastic to get around to get the girth. So, but they hyperextend when they stand up. The obese people walk around in a hyperextended phase. So this might be one that I would probably put in a brace, neurologically intact. You got nothing to lose. Put him in, let him see what he does, and then come back later. I worry more about 3. And believe it or not, the obese people, you can go retroperitoneal with these folks really easy. It all just falls out front. And so you can put an anterior column in, and you might be able to save yourself a level. So I would probably try just bracing this fellow for a little while and just see what he did.
All right, so let's move forward because we're almost ready for the lab. So what am I doing wrong here? So these sprung joints. So fixed selectively, this was, again, the big question here. And again, this is what was done here. A selective fixation was done and a brace was applied because the flexion distraction injuries are the worst, right? And again, this is not my case, but I got this as an inheritance. And we see what's going on. Why do you want to use the microphone power and explain what's going on here?
Sure, yeah, I can't see really well, but it looks to me like the L3 body, that is L3, right?
Yep.
Yeah, that collapsed, and he also translated a little bit, so he failed in both kyphosis and translation anteriorly.
Bingo. So what do you think about that flexion distraction fixation done at the top there? That upper fixation.
The first surgery?
Yeah, on the left, yeah.
Yeah, I think, technically it looks okay. I don't have any issues there, but it's lower. That's T12L1.
Yeah, L1 was the upper level. This is actually, let's go to Dr. Gendelbein. So this is a classic problem. This was a B2 injury, and this was fixed into the fracture, right? So what do you think about that? Because of the problem of this kind of a constellation, once you say A to one thing, you have to say O to the other one and do all over, right?
So could you go to the previous slide, and I'll tell you my kind of school of thought with all of this. So I agree with you that the up top at the L1, that's operative, no question. I agree with everyone over here that L3 would have been my dilemma. In an ideal world, this is a no-brainer. If with L1 injury, go T12 to L2. If I were trying to treat the L3 non-operatively, I'd be hesitant to. I think I would be setting them up for failure by fusing down to right above the L3 fracture. And so while that fracture, if it were in isolation, I would definitely go one up, one down, maybe put a screw in the fractured level. If I was trying to kind of hedge my bets to try to treat L3 non-operatively, I would consider, I'm not saying I would, doing what they did with the thought process that if L3 were to fail, I would be coming for a second surgery anyways. But yes, I'm not a big fan of putting the screw through the fracture, but in this scenario, I would have considered it just to try to decrease the load on the L3 fracture, but I think that's up for debate as well. So it's as clear as mud.
Ali, can you give your microphone to Ashraf? I know you always want to agree with your partner, but I hope you
I don't know.
So burst fractures, can you offload a unstable burst fracture by putting a short screw into a comminuted vertebra? You want to do a short construct, let's say here, this is L3, and you want to do L2 to 4. This is, forget about the fracture above that. Does it make mechanical sense to put a short screw into L3?
For an L3, to put in the short screw into L3,
Yeah.
I think you'd be risking, that it's still, now you just you just translate the fulcrum to tip forward, just a little bit more distal. So you're having a little difficulty understanding your question. You're saying take the proximal construct.
Let's look at the L3 burst fracture alone.
Okay. Yeah.
Pertinent to your comminution index talk before. Is there not a difference by putting a short screw into the burst fracture to decrease the so-called working length of the rod?
Yeah, so I think if usually when we're talking about putting a screw at the fractured level, that's when that fractured level is in the middle of the construct, and there it makes sense. But putting short screws into a fractured segment at the end of your construct, I think predisposes you to that. It adds even more stress to that level. But I think if you're going down to L4...
Hey, no, I meant we're going short segment fixation. So sorry, I'll do it one more time. Bad question asking. L2 to L4, we want to do a short segment fixation. L3 is a burst fracture.
Yeah, absolutely. Putting in short screws absolutely helps. Several biomechanical studies and clinical retrospective series that support that. And the short screw it's a very elegant way to do it. So because it leaves the door open for a subsequent cage placement from the lateral position, but it does increase the stiffness, and you're no longer cantilevering as much because you have a little bit of bite on that injured level.
Yeah, because burst fractures are anterior column pathologies, and if you're adding extra 2 points of fixation through the pedicle posteriorly, you're just further strengthening the posterior column.
It becomes a 3-point fixation. Dr. Hofstetter, you combine amazing endoscopic and minimally invasive techniques, and I've seen your cases. You're also not afraid of putting in some big hardware. I need you to kind of be the final arbiter of what is to be done and maybe what we can learn from what went wrong here.
So I think, I agree that, even though, the short construct that they did on the x-rays up there didn't fail, right? It was L3 that failed. I think, a standing x-ray would have, before the surgery would have cleared that. I think L3 needs to be included there. I think one thing that we have done pretty successful is if you need an anterior column construct and support in a case like this, there are MS technologies where you can accomplish that and sort of get additional anterior support, with different 3D expandable cages. You don't always have to do a corpectomy, especially in those morbidly obese patients. On the other hand, the lateral approach is not impossible either. And I agree. I mean, I think with a big patient at L3, you want to start your concentrate at L4. Some anterior support might be helpful there to, have guaranteed durability.
Would this
Before we move on,
Go for it, yeah.
Can we just go back to the short construct up at L1? So this was a T12 L1.
Yeah.
Is the idea to be putting a lag screw across the fracture at L1, and that's where we're getting the fixation? Because obviously this isn't typically what we would expect from treating a flexion distraction injury like that.
So, David, you are FDI expert. Speaking to the microphone, what do you think about Amir's thought? What went sour here one more time, and would a additional lag screw have helped this?
Yeah, so again, I think what they did over here is they tried to keep the topmost construct relatively short to try to spare stresses on the L3 segment. That's what I think happened here. I understand that gamble. Ideally, the L1 fracture would have gone one above, one below, so down to L2. But then I'd also be tempted to go down to L4 in this case. But I'm just saying I understand this surgeon's thought process, but in this case, it failed.
Well, yeah, because I think Amir's question is a really good one. I think that initial image actually showed that better. And that was that there was a clear, this is kind of that mismatch of the spinous process, the level above is transversely fractured, but then the vertebral body that absorbed the anterior column failure is the one below that. So you basically have a two-level injury, and I think that's what you're saying right there, right now. And so we have to take pay credence to that.
Yeah, absolutely. This injury in isolation, no questions, T12 to L2.
And this is, again, I want to emphasize, maybe you should explain that one more time, the difference of a chance injury and a flexion distraction injury. A chance injury allows you to do this. A flexion distraction injury does not. Can you just put that in words again?
A chance injury is more prone to bony healing, so you could go so you don't need to do a formal fusion. While with a flexion distraction injury where you have a large ligamentous component, you do need to come down and fuse.
Yeah. So that's, I think, a very succinct way to put that. Question to the lab. Are we live in the lab now? Can we have audio feedback? So the final outcome of this patient, from what I remember, I don't have a final image here, I apologize, but he actually did okay, but he was in a brace, but he actually went back to work, believe it or not. He was in a machine shop, and he went back to work, and he kind of stuck it out. But clearly it's a case of more surgery was necessary rather than less surgery, and a selective surgical approach here backfired. And the facet joints, in retrospect, at the bottom level, were the problem, the weak spot.
Yeah, and if you look at the failure there, it does look like there's a bit of translation at the vertebral bodies, so it makes you wonder, like, were the facet joints that you showed earlier a harbinger that this is really a subtle translational injury as opposed to a simple compression fracture?
I thought that was instructive. That's why I put that in there for this little debate panel. But I think all the various components of the 3 lectures before Bob's and the 2 UCSF lectures were very pertinent to this. So hence that. Any final words of wisdom? Wyatt, would you let him go back to manual labor?
Yeah, definitely.
Definitely, yeah.
How closely are you going to follow him that L4 does not get, become loose? I mean, are you going to get a CT scan at 6 months, 12 months? Or
I just get upright x-rays. I like CTs, but these days, I don't know how this at UW, we get questioned for every single study that we order. It's really kind of insurance reality. You have the same thing in LA?
Yeah.
It's nuts. Every single modality has to be justified. So we have an appeals court system now. So I would like to get them. I have to offer a clinical justification that's not just perfunctory.
So did you think about an anterior column construct? Because I could have, in this case, if I would have done it de novo initially, I would have put some type of antibody, like, probably like a small antibody graft just for some support in there.
I would have. I've actually done unilateral takedowns where I take down one pedicle. Ashraf was mentioning it last night in the case discussion, and I put in a simple banana cage after cutting out the disc and the upper body. The success of these burst fracture treatments that I see is whether it's non-operative or operative, this disc has to calcify. If this disc calcifies, whether it's non-surgical, surgical, you have a success. If this disc does not calcify, it'll fail, it'll collapse. So enhancing that either by a patient who's a bone former and having good luck with the physiology of the patient, or enhancing it surgically by taking the disc out and putting a spacer in does make sense to me. With that, Ben, how are we doing with the lab?